Good afternoon, everyone, and thank you for inviting me for this nice meeting. Today, I'm going to present a course in the principle of venous stenting. I wish I was in person so we can be more interactive course. Unfortunately, I was not able to attend, so I'm going to present online, but I'll be available after my presentation live for any questions. So what are the principles of venous stenting? The learning objective of this course first to identify the need for venous stenting and the right candidate to undergo the procedures, list the key performance requirement for venous stenting, discuss the stent structure and design element and the factors that impact stent selection, and explain the key steps involving in the procedure of venous stenting and list the risk and complication associated with the procedures. To achieve that, really, I divide my presentation to the 6 steps. First one, why stent venous stenting? Key performance requirement, venous versus arterial stent, stent structure and design elements, factors that may impact stent selection, and finally, procedure overview. So let's start with the first part, which is why stent venous lesion? Because it relieves symptom and sign. Iliofemoral outflow obstruction can be life-alternating disease, in which patient may experience debilitating pain, swelling, and skin changes, codification, and venous ulceration. So if we stent this obstructive lesion, relieve his venous hypertension, we can alternate his life quality and improve it and relieve his symptoms. The second thing, we already have the technology to do that. Before this venous stenting, the only choice we have to offer this patient is a complicated bypass procedure, which never showed to improve the outcome or quality of life, or to conservative treatment with a compression, dressing, and bandages. Also, there is evidence that quality of life improved significantly after relieving the venous hypertensions. For this reason, venous stent provide a solution to patients with iliofemoral outflow obstruction who may not be getting treatment today or before using the venous stenting. The new venous stent technology is designed to reduce the venous hypertension lower extremity by improving the venous outflow from the affected limb, and the clinical literature outlines substantial improvement in both clinical symptoms and quality of life. So who is the right candidate for venous stenting? Let's see what the society said or recommended about venous stenting. CERSI, the Cardiovascular Intervention Radiological Society of Europe, they said patient with a SEEB clinical class 3 and 6 and chronic venous outflow obstruction should be considered for intervention therapy, and patient with a SEEB class 3 revascularization should be performed if compression therapy failed. But even if the compression therapy was successful, and sometimes they still recommend to do a venous stenting to treat the underlying cause of the disease, like May-Turner syndrome. What about the American College of Tripology, ACP? They recommend venous balloon angioplasty and stenting for treatment of non-thrombotic and post-thrombotic iliac and common femoral venous obstruction in patients with lower extremity pain or edema affecting quality of life, not palliating by compression, and for patients with impending or active lower extremity venous leg ulceration. What about the SVS and the American Venous Forum? They recommend to use a self-expandable stent for the treatment of chronic iliocaval compression or obstruction lesion that are uncovered by thrombus removal strategy, and they give it recommendation grade 1C. Also, a patient with inferior vena cava or iliac vein chronic total occlusion or severe stenosis with or without lower extremity deep venous reflux disease that is associated with the skin changes at risk of venous leg ulcer or even healed venous leg ulcer or active venous leg ulcer, they still recommend to use venous angioplasty and stent recanalization, and they give it a grade 1C. What about the Society of Interventional Radiology? They said flow-limiting obstruction lesion should be treated with balloon angioplasty and or stent placement, and failure to address such lesion has been associated with a high rate of treatment failure or early recurrent thrombosis. What about the Union International Phlebology? They said iliac vein obstruction disease has been treated effectively by balloonoplasty and stenting, but no rating for this recommendation. And finally, we have the European Society of Vascular Surgery. They said in patient with clinical relevant chronic iliofemoral obstruction or in patient with symptomatic non-thrombotic iliac vein lesion, percutaneous transluminal angioplasty and stent recommended should be considered, and give it grade 2AB. So who is then is candidate? In both Europe and the American guidance, they said SIB class 3 through 6 for chronic venous disease. Patients should be stented, but the clinical guideline did not specifically address the patient with SIB class 1 or 2. But it is acceptable by most society guidelines that patient with lesion must be symptomatic to treat it with the venous stenting. So we cannot just do venous stenting just because we see compression or May-Turner syndrome on CAT scan. Patient has to be symptomatic, or he has an ulceration to be treated, and it has to be, as I said, SIB class 3 through 6. What patient should be excluded? The contraindication for venous stenting in general include uncontractable coagulopathy, local systemic infection, patient has a lesion that prevent complete inflation of balloon or proper placement of the stent, and finally, patient whom anticoagulation or antiplatelet therapy is contraindicated. So which lesion should be stenting? Expert opinion, most guidelines agree that a lesion should be both symptomatic and more than 50% diameter reduction or venogram or IVUS, or more than 50% area reduction on IVUS to be considered for treatment with venous stenting. But the only problem is the experts disagree about the minimum degree of stenosis in which lesion should be stented, varying between 30 to 70%, and how to measure the vein stenosis, like example, using the area or diameter against the ideal size or contralateral vein size, as well as the native size of the deep venous system. So they did not agree on this, how we measure the venous stenosis, and again, the minimum degree of stenosis which need to be stented. But everyone agreed that if you have more than 50% stenosis, patient symptomatic, it need to be stented. So let's come to a question. So I'd like you guys to answer this question. Which of the following statement related to the stenting of venous lesion is true? Choose all that apply. Clinical guidance are silent regarding patient with SIB class 3 to 4. This is wrong, because 3 to 6, we know that we have a good recommendation. It's acceptable by most society guidelines that patient with lesion must be symptomatic to be treated with venous stenting. This is correct. Expert opinion typically agree about the minimum degree of stenosis at which lesion should be stented. No, they did not agree on the minimum. So this is wrong. The last one, careful selection of both patient and lesion may be more important than technical skill required to place a stent. This is correct. So the correct answer will be the second and the fourth one. The second question, venous stent provide a solution to the patient with iliofemoral outflow obstruction who may not be getting treatment today. This is correct. Now we go to the second part of our lecture, which is key performance requirement. The key performance requirement really, first in the venous stenting, the sizing. In the venous stent is different from arterial system because it is a large stent and it with variability of length. The second thing, the strength. What means the stent has to have a strength to withstand the recoil of high fibrotic lesion and external compression. It has to be flexible to accommodate the high tortuous venous system. It has to be durable, non-susceptible for fracture, even with a hip flexion, especially we put on young patients, so we're looking for long-term durability. And finally, you have to have an accurate deployment, like an easy and precise and predictable stent placement. So let's go through each one in details. First, the sizing, stent sizing. When we say the size of stent 10 by 40, what does that mean? 10 usually is the diameter and the 40 is the length. The usually minimum size, sheath size for venous stent using 0.035 guide wire, usually between 7 to 10 French. But it's not the big deal in the venous system. Even 10 French with a compression, you can stop the bleeding. You don't need any closure device. The self-expandable venous stent usually sized approximately at least 2 millimeters larger than the reference vessel diameters. Also, in the venous, we need to use a longer venous stent, like 140 or 160. Is desirable to avoid overlapping multiple stents. Overlapping is not good in the venous system because it creates more stenosis and occlusion. And the length, if you measure the length from the confluence to the deep femoral vein, is about 220 millimeters. So you can see here we have a different length. So usually we use a long stent and the large stent, like usually 10 is very small. Usually you go 12, 14, 16, 18, 20, and even larger than that. So there is a debate among venous experts about the ideal diameter of venous stent, but in general, larger stent, more than 16, are the most considerable desirable. So again, always go with a larger stent. Just give you an idea about the size you need to use. If you could talk about common femoral vein, usually you need to use 12 millimeter diameter or 125 millimeter area. If you talk about external iliac vein, usually it's 14 millimeter, and common iliac vein is about 16 millimeter stent. The second thing is the strings. It's very important for the stent to be have enough strings. What that means? It needs to have a radial force when a stent is expanded. So after deployment, the stent will continue to open forces of the stent acting on the vessel wall, and also it has to have a resistance for contracting. And also she has to have a resistance for compression resistant. So the stent has to have a chronic outflow force, radial resistant force, and compression resistant force to get an ideal stent. And usually nitinol has this characteristic. The reason why nitinol is more common than steel in the venous system. And it has the ability to resist vessel recoil and withstand compression and external forces, which is the main key design in the nitinol stent in the venous system. Flexibility is very important, again, because the venous system is very tortuous. Not all stent design can accommodate this tortuosity. The reason why the flexibility of the stent is different from the company to different companies. The reason why it's very important when you use your stent to look at the flexibility of this stent and use the right stent for the right anatomy. But in general, venous stent requires sufficient flexibility to avoid kinking or excessive vessel straightening at physiological bends, especially under the inguinal ligament. Like you can see here, multiple company, and you see when you bend the stent, you see how the kink is different. Some of them are resistant to kink, and some of them are very, very bad with tortuosity and kinking. I think durability is very important. Venous stent must be durable enough to withstand the repeating bending, lateral and axial compression and torsion to avoid fracture. And venous stent design are variable and not equivalent in their durability to withstand this compression. So every company also they have different durability for the stent. So when you choose your stent from each company, you have to look for durability and flexibility, which are completely different from company to company. Accurate venous deployment also is very important. Also, each company has different deployment accuracy, so you have to look at the accuracy. In general, like a wall stent or a braided stent are known to shorten during deployment, which makes the stent position is very less precise and it's very difficult. Where if you look at like nitinol stent, like every stent, they are designed to expand with a minimum forcing, so you can have very nice, precise deployment. So let's go to a couple of questions to this session. Which anatomical location endures the most intense bending during walking and sitting? Usually the inguinal ligament, it has the most intense bending during walking. So the answer will be B. Venous stent design are standard with equivalent durability to withstand the compression and torsional forces. This is wrong, because I said each company has different, or each stent has different durability and flexibility from other stent. So this is false. We go to our third part of our presentation, which is the venous stent versus arterial stent. How is venous stent different from the arterial stent? So let's ask some questions. Are tortuous where veins are muscular and straight? This is wrong. We said the venous are more tortuous than the arterial. All of the following implications are associated with the venous stent design except radial resistant force and compressive resistant. Yes, this is what we need in the venous stent. It has to be a radial resistant force and compressive resistant. High strength and rigidity in the pelvic region. No, we want to be flexible. This is wrong. So this is the answer. Long-term durability, yes, because we use it in young people. And potential need for large cell design to mitigate clot formation at the potential venous confluence. This is correct. So the answer will be B. Now we move to the third part of my presentation with the stent structure and design element. If you look at the stent structure and design element, it's very unique. The stent design contributes to the stent performance. A stent design includes rings, you can see it there, elements joined together in the distinctive pattern, special way, and the ring and element provide a radial strength, while the connection play a major role in the stent flexibility and kink resistance. So you have two components. You have the connectors and you have the rings. The more connector, make it more flexible. The more rings, then you have more rigid and resistant to the compression stent. So you need to balance between these two. So what are open cell and closed cell geometry? You hear about open and closed cell. Let's talk about the open cell design. Open cell design are those where the adjacent element have periodic connection, very small connection because more rigid. The open cell they have more connections, peak to peak connection. They have peak to valley connection and mid strat to mid strat connection. Whereas the closed cell design are those who are where the adjuvant element are fully connected at each crown, and braided stent may be considered a closed cell design. So usually when you heard about braided stent, it's most of it is a closed design. The second thing is that if you look when you curve the stent, if you look at the inner part of the stent, the blue one, you see how it's compressed, whereas the outer one is being stretched. This is when you have an open cell design. When you have a closed cell design, you see not major change in the cell of the stent when you bend it. So what that mean? Stent with open cell have the advantage of flexibility, very flexible, but don't cover the vascular wall as uniform as the other design. Because as you see in the inner part, the stent becomes small. They don't cover as the outer part, which is large. Where if you look at the closed cell design, the stent with a closed cell are generally less flexible, but the open cell stent maintain uniform coverage. So it doesn't matter in the inner or outer, the stent will cover the same areas, no change, because they don't change in the size when you bend the device or the stent. The other thing is that in the open cell device, open cell stent, typically designed to not foreshorten significantly during deployment or expanding. So the open cell, they don't shorten, they stay the same. This is very advantage. Whereas a closed cell design usually provide more uniform surface coverage, as we said before, but they potentially lack a desirable amount of flexibility and suffer significant shortage. So to summarize that, again, the open cell, it has less uniform surface coverage, but it's more flexible and less shortening. Whereas a closed cell design, it gives you a uniform surface coverage, so more coverage, but the price you pay for that, you have less flexibility and you have more shortening. So you have to be careful. The connection is very important. This is the one which gives you the flexibility of the device. So with regarding to the venous stent, it's important to maintain the balance between flexibility and strength. venous stent should have enough connector to prevent kink, but not so many to lose flexibility. So the more you have the connectors, you have more flexibility, but you have a less uh, resistant to the compression or less strength. So you have to balance between these strength and flexibility. Again, the fewer connector may make the stent more flexible, but more connector may provide more strength. So you have to look what I'm looking for. I'm looking for strength or more flexibility when I put my stent. So this way I decide, should I use a stent with more connector or with less connectors? The material also is very important. What material are we going to use it? Are we using steel or nitinol? And when we pick up your stent, what's the difference? In steel, it's usually moderately flexible, but it has an excellent compression resistance and kink resistant. But what's the disadvantage? It's shortened when implanted because the closed cell and does not maintain consistent strength at the end. Whereas the nitinol, it's more flexible, so it can adapt the vessel of varying caliber than a braided stent. So if you have to put it from 14 or 16 to 12, it can accommodate the different in the diameter of the vein. Greater resistant force than a braided steel and has a predictable length, so does not shorten. So what is the disadvantage of the nitinol? Slightly less compression resistant than braided stent and does not have demonstrate durability in the area of flexion. This is the only two things. But in general, the majority of the stent we use is an nitinol stent. Deployment mechanism, we have either the stent, either could be a balloon expandable or self-expandable, but the most commonly we use is the self-expandable stent to treat the iliac vein compression. Why is that? Because a longer length, self-expandable, you can have a long one, like 100 or longer, whereas the balloon expandable are usually short. And the self-expandable more flexible, whereas the balloon expandable are rigid and less suitability to permanent deformity by external forces. So what that means, when you have a self-expandable stent, you have a force, it can bend, but can come back. It has a memory. Whereas self-expandable stent, when it's compressed, it has no memory, stay compressed. So this is the main difference between the self-expandable and balloon expandable. And again, the majority of the time we use a self-expandable nitinol stent. So let's go some questions. What are the advantages of self-expandable stent treatment of iliac vein compression? Choose all applied. Shorten length? No. Self-expandable is longer. Increased flexibility? Yes. Rigid and strength? And the last one is it rigid and strength? No. Usually the balloon expandable is more rigid. Less susceptibility to permanent deformity by external forces? Yes. So the flexible one, it has long, increased flexibility, and less susceptible to the permanent deformity by external forces. Whereas stainless steel is deformed permanently by external forces, is more rigid, and less flexible and shorter. So the answer would be B and D. Closed cell stent provide more uniform surface coverage, but potentially lack a desirable amount of flexibility. No, this is wrong. This is the opposite. This is the closed cell. Yes, this is correct. The open cell is the opposite. So closed cell, yes, give us a uniform surface coverage, but less flexible. Whereas the open cell provide less uniform surface, but give us more flexibility. Now we go to the number 5, which the factor may impact the stent selection. There's a couple of questions we need to consider when we decide to choose our stent selection. Can you visualize the stent in the position? It's very important. Can I see the stent? It's very well visualized on the X-ray. Can I handle the tortuosity or the diameter of the changes? You have a big, so is the stent flexible to take the tortuosity, and like nitinol can accommodate the change in diameter when you have large and small vein, or you go like from cone iliac to the IVC. Does it have the radial compression strength to stand up the amount of compression? If you look about severe compressions, you may think about stainless steel. where it covers the entire venous lesions, where the stent is going to be deployed or overlap. Because overlapping is bad in the venous stenting because it has more venous stenosis. And can the stent be passed safely to the target vessels? Another two questions. What are the links and diameter requirement for the disease segment? I'm going to choose a stent for it. What is the location of the lesion and what type of lesion is it? These two questions must be considered together along with the recommended size and eye view by the company. But in general, if the venous stent is undersized, the stent may not maintain a position and migrate to the heart. And if you over-exercise, the patient may end with a pain. So it's very important to choose the right size. And for the stent, because again, oversized, you can patient end with a pain. Undersized may migrate to the heart. So you have to be very careful. So these two questions very important to put in your mind when you choose your stent. Another question, are there delivery restrictions posed by the disease access vein, sheath size, visitor tortuosity, working room, or distance to the lesion? Can the number of required stent be minimized? Because the less stent number will be better, because less overlapping and less problem. Is it in your inventory? Do you have this kind of stent? What inventory you have? The risk of puncture site bleeding increase when the large sheath is passed through a diseased common femoral vein. So you have to put back in your mind when you choose the size of the sheath and the stent. The distance to the lesion is important. Then you may have to go from popliteal or even from the tibial vein if you are dealing with a lesion close to the common femoral vein. The sheath size and access site may influence the choice of the stent. And finally, make plans for or consider alternative access site if necessary. Again, if you think you are going to be very close to the stent deployment area, try to use an distant access site like popliteal vein or even sometimes tibial vein. So let's go to question. What are the questions considered when you're selecting the stenting? The lengths and the diameter required for the disease segment. This is correct. The maximum number of stent that can be used. No, I need the minimum number I want to know. I don't want the maximum number because I need to minimize the number of stent I need. So that is why I need to use a long stent to minimize the number of stent. The more stent you put, more overlap, more problems. Delivery restriction posted by the disease access vessel, yes, because it may, change your plan. And of course, the type of the lesion is very important. It's compression, or it is fibrotic, or it's post-thrombotic, so you have to know that. So this would be the answer. If the venous stent is excessively oversized, risks include what's going to happen, patient end with a pain, so patient pain. If you undersize, then patient may migrate to the heart. Now we come to the final part of my presentation, which is the procedure overview. The procedure requirement, you need two parts. You need a capital investment or equipment, like a duplex ultrasound, C-arm or cath lab. IVAS is very, very important to determine the extent of the lesion degree of stenosis. I cannot imagine, guys, you do a venous intervention without an IVAS. It's very important to invest in that. Disposable, of course, equipment like high pressure balloon, because we are working the venous system, different from the arterial system, so you need high pressure balloon to break the forces and fibrosis, guide wires, and the sheath. So what the factors that determine the procedure success? Clearance of the preoperative thrombosis. If you have an acute DVT patient, be sure you clean all the clot from the venous system, because the more clot you leave it, then you have to stent it. You have put more stent. The more stent you put, you end with the more trouble. Establish of appropriate venous inflow and outflow is very important. You have to go from healthy to healthy, normal to normal. So you have to have a healthy inflow and outflow. And you need to cover the entire area of stenosis. You cannot leave any lesion. So it should be covered from healthy to healthy or normal to normal swing of the vein. And finally, you need an adequate luminal gain. You have to be sure the stent is completely expanded, and the IVAS can help you a lot with that. So how we do the procedure? First, we get an access. usually popliteal, femoral, or internal jugular vein sometimes under ultrasound guidance. Secure the puncture site, maintain guidewire placement, deliver the sheaths and therapeutic catheters, and maintain access for venogram of the treatment site. Getting access too close to the intended treatment site can lead to the difficulty with the stent deployment. Second thing, pre-stent deployment. Consider the need for removal acute clot in DVT patients. Very important. Again, if you still have residual clot, keep the patient 24 hours more on thrombolysis. Interprocedural imaging is used to determine the appropriate stent size, identified of the disease segment. The reason why the IVAS come very handy. Measure the lumen and vessel reduction secondary to the obstruction. IVAS imaging to assist in determining the degree of stenosis and length of the lesion. It's very important, the IVAS. Don't depend on venogram. Choose the stent size per institutional preference. Determine the target vessel size. So you need to use the right size for the right stent for the right vein size. And again, always need to oversize at least 2 millimeters. I use balloon to protect the vessel of at site of the lesion. If you don't know how much the size is, you can have IVAS, at least use the balloon to get an idea what the size of the vein, because you don't want undersize into the embolization to the heart. Venous stent usually performed immediately after venoplasty. Procedure overview, I'm not going through that because different from company to company, what step you do, it depends, what stent are you using, self-expandable or balloon expandable. This is an easy steps, but you just have to follow the instruction of each company and which stent you are using for your procedures. And finally, post-procedure deployment is very important to use balloon dilatation. After that, after you put a stent, to optimize the lumen gain. It's very important to get a complete lumen gain. Use imaging to confirm that the stent is fully expanded, especially use an IVAS. We use an IVAS, be sure stent completely expand, otherwise it will be thrombosed, and access for patency and in-stent restenosis during follow-up. So what are the risk and side effects of the venous stent? Venous stent considered safe, minimally invasive procedure with serious complication only happening on rare occasion, or if you don't do good planning or you pick up the wrong size of the stent. Serious complication could be pulmonary embolism, but even though radius happen, the reason why you don't use an IVC filters when we put a stenting, even with a DVT. Hematoma, bleeding, sepsis, stent fracture, stent migration, if you undersize, venous occlusion, restenosis or thrombosis with within or outside of the stent segment, vessel damage, intimal injury, dissection, perforation, or ruptures. The other general risk for venous stenting, allergic reaction to the stent, in-stent restenosis, bruising or bleeding at the access site, pseudoaneurysm, back pain, also be experienced during the process of pre-dilatation and stent placement. The reason why, if we have a long fibrotic vein, we need to balloon and stenting usually and do it under general anesthesia because it's very, very painful. And even after a couple of days, you have to give a good painkiller for the patient because they have a lot of pain after they leave the vein and put a stent. But again, don't also oversize the stent because this also can give you a chronic pain. So it's very important. But again, even though it's a simple procedure, percutaneous procedure, but many times I do under general anesthesia if I have a long fibrotic vein, because I think this vein will be very, very painful for the patient. The potential complication of venous stent, you have an acute complication which may occur during or immediately after the venous stent replacement, like infection at the access site, occlusion may occlude it as a result of venous thrombosis, or as a result of placing a stent that's not fully opposed to the vessel wall or not fully expand, or could happen after venous stent placement. Additional dilatation is usually performed to be sure that the stent is completely open for nitinol stent, or ensure for opposition of the stent if used stainless steel stent. Migration or embolization of the stent, it happens if you undersize the stent. The mortality rate after endovascular revascularization is low, ranging from 0 to 1%. The most common complications are early thrombosis, less than 30 days, and late thrombosis more than 30 days. The reason why you need to be very aggressive with the anticoagulant from the intraoperative and day one, because the most stent thrombose really very quick within 30 days. This is different from the arterial stent. Chronic complication usually happen over time. Recurrent stenosis. If it's occur at the edge of the previous placed stent, you can overlapping stent is placed. Stent damage, it can be damaged by external forces. Chronic repetitive motion and bending, compression, and twisting can lead to the stent fractures. Some speculated that stent beneath the inguinal ligament or overlapping stent beneath the inguinal ligament may be associated with a stent fracture, but this is nothing. Nobody proved that. You can cross the inguinal ligament with a stainless steel stent and reported similar patency and the same as if you put it in suprainguinal segment. So crossing inguinal ligament with the venous stent is not a problem like an arterial system, and it is safe, and nobody showed it increase your restenosis or occlusion rate. The most important is that good inflow to and outflow from the stent segment is very important to maintain patency of successful iliofemoral recanalization. So again, the key is that you have to have inflow and outflow. You have to stent from healthy to healthy to get a good outcome, because venous system is low pressure system, can thrombose very quickly. If you don't get from healthy to healthy, you end with the early thrombosis. So last question now, what are the procedure requirements? You need a capital requirement, high pressure balloon, sheath, the above, of course. The last thing, IVA is the most accurate imaging modality to evaluate iliofemoral outflow obstruction. This is good. Thank you very much for your attention, and I hope I give you some overview about the principle of venous stent, and I'll try to be live with you guys to answer any question. Thank you very much.